The founder of Silver Buddy program.
Good morning, my name is Tarika Dorner. I'm the project manager of Housing Policy Training Outreach with the Georgia Department of Community Affairs.
Speakers that talk about what was, what is, and what we can do together. But just to be clear, redlining is a process which was legal at a time of systematically denying credit and insurance access to residents of specific neighborhoods, often based on race or ethnicity. And so while Archie is based in Atlanta, we know that so many places across the nation, in the southmost parts of those cities, are hot. They're hot for all of the wrong reasons. They're hot with respect to increased morbidity, mortality, and compromised quality of life. And that is what our work today and discussion related to redlining and how health and healthcare are connected to that and what we need to do together. So I challenge you to be reminded of what is, to develop partnerships and networks that are important to the now, and for us to make strategic action steps to be able to advance population health, health equity, and health justice. Enjoy the day.
So in the context of public health, we have been working alongside other universities in collaboration to promote healthy attitudes and behaviors. And one of these examples is trying to show you what happens in your body if you become vaccinated. And one of those things where you can't really see what happens inside your body. For those of you with kids, it's sort of like the magic school bus, where you get to kind of travel inside somebody's body and try to see what happens before and after you receive a vaccine. And so I can tell people until I'm blue in the face as an expert, they will not listen. When people listen and they believe, it's what they see, hear, and believe. And this is where the immersive platforms come in. So when they have seen the vaccine work inside of someone's body and they're able to fight the flu virus with their own two hands, this is where people start to believe the things that they have seen and heard, and this is where we're starting to see a lot of the behavior change over time. We have also started to work with a lot of climate-related and environmental justice-related issues. Another one of these things where it's so far off in the future, people really can't link the cause and the effect together because it's something that they feel like is not going to happen immediately. And so I don't know if you've seen the movie Don't Look Up. Yeah. We are working to share realities with other people. Again, we're not asking you or people to be Linda. You will never become her. But you can listen to her story within a shared reality, standing right next to her and traversing through her life story as she tells it. And so we've been taking this out to the community in various events, working with community fairs and local events to try to get a lot of exposure to people's feedback and what they feel about this particular story. We also take a lot of K through 12 events as well, and so we've gone to schools, and what's really interesting is that a lot of the children will come up to me afterwards and they'll say, I hate history and I hate science, but that was great. And so this is one of the rare opportunities where we see kids lined out the door, like they are waiting in lines to come experience something. This is very different from us trying to, let's say, pass out a pamphlet or have them watch a YouTube video. They are in there, they're feeling, they are hearing, and they are sort of walking through this experience with us. We have also worked pretty closely with the Emory School of Medicine, and as a part of the first year students' programmatic training, we have exposed all of them to this redlining experience so that all of the first year students have exposure to this redline experience. And so what we know about these virtual and immersive stories are that they're embodied, and it tends to reduce that psychological distance, the counter arguments, the feeling of us people feeling like this is not them or not relevant to their lives, it really dramatically reduces that psychological distance that people have about this issue. And affect matters. It's not just critical thinking, it's also feeling and sharing the emotions that people have about these issues that really matters. And virtual reality is very strong and extremely powerful in being able to get people to share that emotion. So not just think about it in a completely rational way, but also share empathy. And then finally, sharing reality and creating this common ground where people are now able to have a conversation together about these very controversial issues is critical. The first step in trying to get them to get into a different state of mind, if you will. And so creating these shared experiences where they're walking alongside someone.
Yeah, I have an Atlanta history podcast I've been doing for 8 years with 317 episodes. So they're all very short. And part of the reason I do this is to present what we've done. Sometimes we've had great ideas, sometimes some bad ideas, and I have absolutely no idea how to fix any of these things, but I love presenting about them to the people that can, so that they can take this information and do something differently. So, if I can get this to work. Health begins before healthcare, so that's kind of the theme of the presentation. Long before we built our first public hospital, the decisions about who lived where waste went, where water flowed, who received public investment, who didn't. This is redlining before official redlining of the 1930s, which we're going to get to at the end. Some people have seen this. It's a great slide. The Atlanta Regional Commission shares it often, but what if your zip code could predict how long you live? In Atlanta, it does. And there is more than 10 years difference from someone that lives in Buckhead to someone that lives in South Atlanta. These are real statistics, and hopefully today I can explain why these things have happened. So 1850s, if you don't know Atlanta's history really fast, in the 1830s, the railroad comes to town. By 1845, we're named Marthasville. By 1847, we are named Atlanta officially. And it's a small railroad outpost, about 2,500 people living here. So the 1850s is our kind of earliest start of Atlanta. The very first doctor, Dr. Joshua Gilbert, first white doctor in the city, moves to town in 1845, and he would actually blow a whistle as he rode through town, and you sort of had to wave him down, again, if you were a white person. This is because enslaved people were considered property at this time. So while there was a monetary value attached to them, so there was some money spent on their health care, but very little. As you can see, it's estimated about $3 per enslaved person is spent on their health care. Also with enslaved people, you have white scientists and doctors often using these women and children in medical experience and procedures, and also almost all of the early Black people in Atlanta's history, the bodies were donated to science. If you look at the bodies of people who were Chattahoochee Brick in the convict leasing system, if you look at the Black women at the Fulton County Almshouse, which the building is up near in Buckhead right now near Chastain Park, if you look at these death certificates, every single one of their bodies were donated to science, against their will or by their choice. For white people in 1850s Atlanta, it's not the best healthcare system. Hospitals are not associated with a place of care. They are where you went to die. Again, you're kind of flagging down the rural horse riding doctor, and that's all that was available. Sewer, processes like that. When we think about healthcare, we usually think doctors and hospitals, but for most of Atlanta's history, your greatest health risks weren't inside a hospital. They were the water you drank, the streets where you lived, and whether the city invested in your neighborhood or not. So how did the first Atlantans get water? They used buckets. They would take buckets to a stream and they would carry it back to their house, or they would use rain barrels. Wealthy Atlantans were able to build cistern and spring pumps. And so this is why almost every historically wealthy neighborhood, places like Inman Park, they were built where natural springs existed. Even places like Wormwood Park, if you're doing history on early Atlanta neighborhoods, I bet you there was a natural spring there, and that's where white people built their neighborhoods. Also on high ground, but we'll get to that in a second. So city council, in 1850, we had a big fire City council's like, okay, we gotta have a fire department, we gotta get ourselves together. They lead the charge to construct a 5 by 5 foot well that was at the corner of Mitchell and Whitehall. Today Whitehall is Peachtree Street. Now, while this photo is of a well in Macon, I think this is what our early wells pretty much look like. They're literally just holes in the ground, covered by planks, maybe a structure over them, and this is how we were doing water. In 1853, Atlanta's hit with a smallpox epidemic, and so we start to see the need for some changes and maybe a public hospital. So before we get to this slide, which this is our first waterworks, after the Civil War ends in 1864, there are 3 main, what they called shanty towns at the time, which is where the newly emancipated Black Atlantans chose to live. The main ones were Shermantown, Summerhill, and Jenningstown. Jenningstown is where we are today, yeah. Jenningstown is where today the AUC is. By the way, it's actually the only shanty town that was on high ground, which is, a lot of people talk about land memory and why are all these HBCUs here? It was a magical place. The redlining map, which I'll show you in a second, many neighborhoods had already spent decades not receiving public investment. We've created the map before. Redlining simply froze these patterns into place. So if you've ever seen the 1938 Homeowners Loan Corporation map, this is the redlining map. It is marked with grades. I'll just try to put up there. So green is grade A, it's the best, homogeneous, native-born white people. Blue, grade B, still desirable. Good solid neighborhoods, usually entirely white and US born. Yellow was definitely declining. These were often working class, ethnically diverse, first or second generation European immigrants. And then red, grade D, which was hazardous. This was the riskiest area. Appraisers explicitly downgraded these neighborhoods. They contained undesirable groups, including Black, Asian, Mexican, and Jewish families, and lower income residents. If you take these maps, I wasn't really able to make something that worked visually, but these are the same maps when you look at the sewer maps, when you look at the neighborhoods that were just invested in, when you look at anything from history, if you overlay this map, there's actually, I think it's Georgia State has an Atlanta Studies, I think it's called atlmaps.org. It has a great functionality where you can slide the maps back and forth and look at these things sort of in real time. So we started with that same question. What if the zip code could predict how long you live? When we say health begins before healthcare, this is what we're talking about. By the time someone enters a doctor's office, decades of decisions about housing, infrastructure, transportation, education, public investment, they have all been made long before, and they shaped the possibilities of these people's health. That's it.
In community development, affordable housing, and so it's wonderful to be in spaces that understand how critically important housing is. Housing is preventative health, right? Anything that you want to tackle in a person's mental health, their physical health, their family health, stable housing gives you a great place to start. After that wonderful presentation from Victoria, I also just want to point out that public policy is written and enacted by who? People, right? And if you devalue a human being, you will see the places where they gather and where you put them as valueless. So let's start within hearts and minds and doing that work of equity and justice from a personal starting position. Take your journeys, right? Then you will begin to write and support and enact policy that is equitable and just. Thank you so much for that moment of personal privilege. I have an incredible panel here with me, and since we are keeping it tight and right on the agenda, please do read their bios on your table. We are going to start with Pastor Thomas, who you see here is with the St. Peter Missionary Baptist Church and chairman of the Metro Atlanta Ministerial Alliance. Pastor Thomas. Faith communities have long been anchors in neighborhoods that experienced the sharpest effects of redlining. Where do you still see those effects showing up today in the communities where your church and the Metro Atlanta Ministerial Alliance serve? And what is the role of trusted institutions in rebuilding health and wholeness?
Well, I think that the main thing that that takes place now and it continues to develop and grow is that so many people, because of the lack of investment in communities, have been redlined. Many people who are in the communities, when they reach a certain level of ability, move out. It's hard to own a house and take care of your property. The house next door on either side is full of trash and kind of dilapidated. So what we find out in the communities that Metropolitan Ministerial Alliance serves is that people typically move away, and so that takes away some of the key leadership in our churches. It takes away from a very practical perspective, not that this church is about money, but from a practical perspective, people who are able to give to allow us to do more ministry move to suburban areas. One of the things I found interesting is younger pastors come into ministry and pastoral ministry. They are more desirous of living in pastoring in Henry, pastoring in Fayette, pastoring in Cobb, pastoring in Conyers and Covington as a result of the fact that those areas are quickly developing. So it's as if in our cities things are diminishing while in our suburbs things are growing. And so one of the things that we have to do, the churches that remain, and I personally believe that I was called to pastor in urban areas, so I hadn't considered the option of leaving town. But I think that one of the things we must do is kind of engage those who are in community to kind of empower them to be able to do more, to stay in community. In the neighborhood I serve, West, which is kind of Oakland City, Sandtown, Venetian Hills, the Campbellton Corridor, there's a whole lot of people who rent. And they rent from one person who owns about 40 houses. And those houses are not maintained, not monitored, they're just there. And so we're trying to get people to be in a space where they can engage in more home ownership. And that's something we have to do by partnering with credit unions, banks, developing people accounts. When you partner, if you get enough people, that's my position, you get enough people at a bank, you can kind of lean forward and try to get them to do more loans. So that's something that's taking place with something we're actively trying to engage in addition to trying to make sure that the houses, the legacy residents that live there, make sure that we help them maintain their properties. A lot of times that's a problem. You get older, your income is locked and everything else is rising. We've tried to help do roofs and help people maintain their houses.
So it sounds like the church plays a tremendous trust role in people's health. There's a role of trust in health. Would you agree?
Absolutely. The church is a trusted voice. Most people that come to church, or even if they don't go to your church, they kind of trust the leadership or trust the work that the church does. The majority of churches in Atlanta now are what we call community-based churches. That serve their congregations made up of 60 to 70% of the people who live in that community. And so we become not only the pastor of our congregation, but the pastor of said community. Like I never look at myself as pastor of just St. Peter. I pastor Oakland City, Adamsville, Venetian Hills, and so forth. And so we are a trusted voice. And so as it relates to health, whether it be health promotion, health education, whether it have to do with housing, whatever it is, we'll get that question asked. If somebody goes to jail, we become a probation officer, whatever is needed, that's what the average community-based church does. So that's why our voice is important, and that's why these forums, and I really admit I've learned a lot in the last year and a half of marching forums, and so that's why it's so important, because we get to take back to community not only good information, but possible solutions.
Last follow-up for you. What about the role of power building? We heard about how power was guiding investment and directing things in certain ways. How are faith institutions with their trust and connection to community helping to build up power?
Well, if you look, power kind of comes in 2 or 3 ways here in the South and cities. One is political, the other one is economic. I'll just stop at those 2.
Keeping it tight right on.
Yeah, I got to keep it tight, yeah, political. And so one of the things the churches have to do, and Mr. Mosley and I, who's an expert, who's a historian, an Atlanta legend, and I had this conversation all the way up until we came up here. Basically what the church, the voice of the pastor has to be more than just the scripture. Now we love scripture, but we have to talk about things that are relevant to community, relevant to people, to empower them in ways outside of between Genesis and Revelation. We have to speak to them about what's important. And in doing so, voting, who to vote for. And I know they always tell us you can't tell people to vote for, but we know some people are more likely to support the things that are important to us. So we have to stand in our authority, use the voice we've given, not for frivolousness, but for important, transformative activities and transformative processes and even transformative vision. Where are we going next? What's our path forward?
Thank you. The legend can wear sneakers like that on Friday. I love it.
That's right. That's right.
They look so good. They look good.
I love it.
Love it. Mr. Mosby, the effects of redlining do not stop at the door of the hospital, right? They follow the patients right in. Where do you see historic inequities showing up most clearly in patient outcomes and access at Grady today? And how is the health system thinking about addressing not just illness, but the root causes that drive it?
So thank you very much for having us, Archie, for doing this. This is great. So you heard a lot of, in this last presentation about Grady, after 1965 when the hospital was desegregated by court order, and you start getting a diverse voice and how the health system actually deals with the community, we started doing a lot of work in pushing healthcare back to those communities that actually were being redlined. There are a lot of communities where coming into our hospital, you see a high rate of cancer, you see a high rate of obesity, high blood pressure, and they actually follow these communities that have been redlined. We've actually started the process of pushing healthcare back to the communities. In 1973, we opened up the first community health center in the city of Atlanta from a hospital to push healthcare back to the community where it's being done. So we have a number of programs internally where we're trying to make sure that we treat patients. We're correcting a lot of the negative that you heard that happened at Grady at its onset, that how we actually deliver care today. We have mobile integrated health where we actually take health to the person's house. We send providers actually to homes to actually treat patients right there in their homes. Convalescing in homes is actually the best way to do that. We also are doing a number of initiatives that really speak to those areas that have been redlined, that we want to actually deliver care into those communities. I know we have a short period of time here, so I don't want to.
I think we could hear one or two of those examples if you'd like.
Well, sure. So for us, we really, one of the more exciting things, I'll put this item before I forget about it, was that we actually are engaging the next generation of youth in a program to introduce them into healthcare in those communities where they have been historically redlined, so they can see healthcare as a career pathway. This is a way actually to disrupt a lot what's going on in those communities. But that's just one thing there. We've also done a number of initiatives that really look at how we deliver care in those spaces where these communities, Grady is doing a lot of different things because we are an institution that not only are training the next generation of doctors, but we're also training the next generation of nurses. And so we're doing these programs, we're doing a number of programs around healthcare in a lot of major disease areas that we're making sure that the community gets exactly what it needs.
Thank you. Some of the ways that we talk about redlining tend to focus on housing, and we will talk a little bit more about that, but it also touches food access to transit and transportation, you heard education. Around things like food access and healthy food or getting to the hospital, you talked about just now going out to people, so maybe that's part of addressing the transit redlining or the transportation challenges. Are there any other aspects of redlining like food access or education and awareness that Grady's working on?
Absolutely. We've also initiated a program called Food is Medicine, so we want to make sure people understand that what you put in your body actually affects how your health care is delivered. We also partner with Uber and Lyft to make sure we get people to and from hospitals who don't have access to MARTA or what other transportation. If you look at the average profile of a patient that shows up at Grady, they might not have a car. They may not be employed. They may not have a level of education. And so we meet people where they are. We deliver health care in a way that they can actually digest it so that they can actually begin the process of advocating for their own health care.
Thank you so much. Hello, my friend. Hello. LaShawn, redlining didn't just shape housing, right? We've heard already how it has shaped roads, where businesses are invested in, where political power has landed. From where you sit in your career and work, where did these civic effects civic effects still show up most acutely? Where do we see that? And what kinds of investments or cross-sector partnerships are most critical to building healthier communities today?
So I think I'm excited that we're having this conversation because most people think about redlining and think about housing itself, right? And I think the presenter shared with us that it was really about investment, right? It's really about what neighborhoods received investment or disinvestment. It was really around, redlining, and it was said earlier, just reinforced some of the inequities that were already happening, right? And probably brought it to the forefront a bit boldly because it was legal in a sense. When I think about how it's still showing up today, if you look back at the slide that was shared about life expectancy, there was clearly 13 years between if you lived in Buckhead to if you lived in South Atlanta. Today, let me be clear, today there's still a 13-year life expectancy loss for Black and people of color that lives in South Atlanta. And that's still a huge issue. So it's still about investments or lack of investments, right? In our roads and our parks and our housing and the infrastructure, how highways are being built or expanded, right? If I want to be a little controversial, how the Beltline is either helping or not helping.
Questions that need answers.
It's an infrastructure that was promised that was going to have a transportation module that helps to move low and income families to job centers. I don't see no infrastructure. And we're 20 years later, and I was the MPU chair that helped to usher that in South Atlanta. So where there is some connection to, and don't get me wrong, the health aspects of it is really great, it's still a lack of investment. So that's still part of the issue that we're still dealing with redlining.
Just a quick follow-up there. So how do we ensure that communities are partners in solutions and that the full vision of what is offered actually comes to be? Like that accountability moment, Grady was built and there was supposed to be a Black hospital and eventually they got the old, so you can't say nothing was done, but it was not the original full vision that was pitched, shall we say. How can communities really be included and get their seat at the table in as partners in solutions?
I think that communities continue to be partners at the table by thinking about which institutions really are trustworthy. And I think about the work that I do with Morehouse School of Medicine, and that institution has said that this is just more than healthcare, but it's really about the health of the people, and that we have to do this in partnership. So when I think about, the grounds that we sit on, the HBCU, I still think that there's an opportunity for us to be able to shift the dynamics, but too many communities are looked at as just asset deficient versus what are the assets that are there that we can build upon. And I think that, Reverend Thomas said it, I think that we have to make sure that we share with our communities what power they have so that we can have policies to be able to reinforce what is it that we want in our communities. Even today, being in Atlanta, it's a great city, people rave about it, but I still think that we have to have more political power to invest in our communities so that those communities that have had many years of disinvestment are the first communities to start to improve. But that doesn't seem to happen, and we don't seem to have the political power to make it happen. Or do we? And so that's the question that I leave with the audience. Where's your power?
Okay. Jamie, the amazing lineage that we got a little taste of in the presentation, Dr. Eliza Ann Greer, Dr. Georgia Dwell, that lineage runs directly to the Center for Black Women's Wellness. And so I want to ask you, the legacy of redlining has a very specific and particularly devastating impact on Black women's health. We also know that so much of the knowledge we have today was built on Black bodies and research and unethical practices. So please help us understand how this link and how these inequities are showing up most clearly today for Black women's health and wellness, and why is it so important to center Black women's health and wellness?
Thank you. Well, I guess I want to first start by just acknowledging when we entered this space, the opening with health equity, that it still matters. We can talk about it in this space. And I kind of had whew, we could talk about it. We could talk about the impacts of race, the impacts of historic disinvestments. And so I just wanted to, just start by saying thank you for setting the stage and thank you for the presentation. Because I don't know, I'm sure seeing everyone taking pictures of the slides, that there was probably a collective righteous anger around what has happened, not just in Atlanta, but everywhere. Everywhere. And I think about systems that were designed to intend harm. Even, again, beyond just housing, they were designed to cause harm and perpetuate harm. And it's interesting when you talked to Reverend Thomas about pastors wanting to not pastor in the city of Atlanta and maybe go to Henry County or Cobb County, because people have moved, and I say to myself, are Black women really healthier in those counties? They're not. Why is that? And we're entitled, choice, we all have choice, and people should live where they want to live, and it's a wonderful thing, but are we healthier? Are Black women healthier across Metro Atlanta? They are not. I think about Henrietta Lacks, you're talking about Black women in medicine and how her cancer cells were taken without consent. So the medical community has benefited from harming Black women. I think about the fact that regardless of income, insurance status, or anything, and this is where I go with this, wherever you live in Metro Atlanta, Black women are still more likely to be impacted by maternal mortality and morbidity. It's a fact, regardless of whether you graduated from Spelman or had no education. Your outcomes are poor. And so some of the things that I think about, of course, everyone in this room knows about social determinants of health. Yes, we as an organization, and I forgot to talk about the organization, the Center for Black Women's Wellness, we are a community-based nonprofit in Atlanta. We're around a mile or two away in Mechanicsville, and our mission is to improve the health and well-being of women, families, and communities, centering the unique needs of Black women. Veronica, our amazing outreach worker, is there at the table, so please stop by and see us. And so we are, we provide health care to those who need it most. So we provide health care regardless of your ability to pay, regardless of your insurance status. We provide a large number of programs and services really centered on maternal and infant health, providing support to moms and their families around navigating services, wraparound support, education, and the like, and then some work around economic well-being. And so with all of that, it's around those social determinants of health, right? We're all connected, we're not living in silos. And we know that these factors around housing, around transportation, around income, all impact health, okay? I want to say also a little bit about weathering. There's a lot of research around weathering and around the constant daily stress from racism, sexism, and social disadvantage that literally wears the body down. And that's what, I think about a lot of that in terms of the disparity in terms of longevity, in terms of, premature death. And a lot of it is due to weathering. And so the weathering and the impact on Black women, there is a big impact on infant outcomes, prematurity, low birth weight. And, okay, I gotta wrap it up. So, we're okay, all right. So I just want to say, I will say a couple of more things. One, I do want to acknowledge some of the work. I see Tamara Mason with March of Dimes. And I want to talk about a guaranteed basic income project that we were involved with them. Because again, I'm talking about income and economics and the impact on health. and all of this being interconnected. But this was a wonderful, exciting project where there were 25 women around 2 zip codes with the highest prematurity rates, okay? So it was zip code based, and these 25 moms, and I see Rosalind there, and I see, and it was such an amazing part of this project as well. So we worked with March of Dimes and some other organizations, recruited 25 moms in these 2 specific zip codes. They got guaranteed basic income. They got, was it $1,000 a month that they could choose how they wanted to spend that money. They got access to a doula, which is childbirth support if they wanted it. They got access to a year's worth of diapers. All kinds of wonderful support. Because a lot of times we want to say what people should do, what poor people should do with their money. Well, you know what? Is anybody telling us what we should do with our money? Not that, we're well off or anything, but you get the point. And so one of the things I loved about the project is that around the social stressors, because I'm going back to stress and its impact on the body and impact on health, is that around 6, I believe, I'm looking at to Mary here because she's the expert here, but it was nearly 70% of women that were part of that program said that they had experienced less sense of hopelessness. And so I sit with that when I look at the evaluation findings from Emory. It's like, what does it look like to have less hopelessness? Think about the hopelessness that we have in community because of these impacts of redlining, inadequate housing, transportation, things like the Beltline that we thought would provide access and didn't provide the access that we needed. And so there's something to that. What does it look like to decrease stress, to increase social support, to increase financial stability on ultimately the health outcomes of not only the moms but the babies and reduce prematurity? So I wanted to lift that up. The last program, and the VR project, I'm very proud of the staff that participated in that, in helping to train people and think about how to be in someone else's shoes and the impacts of redlining. So I want to shout out to my team that was involved in that. Very proud of that. And the last thing is just around some work that we're doing with Emory around environmental screening. I'm saying environment just because the built environment matters. And so our providers now are doing when you come in as a patient, as part of your social determinants of health screening, you do environmental screening. And that has been really amazing. That has been work that has taken, I have to read my notes on that one, sorry, but what we have really been able to do is examine the environmental factors that may contribute to respiratory illness, lead exposure, think about poor housing, tobacco exposure, housing concerns, chemical exposure, think about, again, the built environment, and other preventable health risks. So just excited about that project. I wanted to lift it up because I don't get to talk about it much, but we're really excited to be a part of that, to again do our part as a health organization, but looking at health in its broadest of contexts and making sure that all women, families, and communities are whole, healed, and well. Thank you.
That's wonderful.
I'm Chief Impact Officer at United Way to just help us close, and then I'll have a couple announcements at the end. Come on up.
Thank you, Jeff. Let's bring this down for the vertically challenged. Good morning, everybody. Good morning. Before we leave, and I know that there's lots of stuff that we want to do before we leave, including continue to talk to each other, I want to thank Jeff, I want to thank the Archie team, I want to thank the presenters this morning, the panelists, and everyone here. As a co-founder of Archie, United Way of Greater Atlanta is so proud to be part of a partnership built on a belief that we make more progress together than alone. This morning, we reflected on redlining, health inequities, and the very long continuing shadow of historic decisions that cast implications for generations to come. These conversations matter because they remind us that the conditions we inherited are not the conditions we have to accept. What we see today is the result of choices, and different choices can create a different future. At United Way, we talk a lot about every child having a fair shot. To me, that means having access to the opportunities, the relationships, and the support that help people build a good life, whatever good life means for them. And that's why conversations like this one that we're having this morning matter so much. We all know that families don't experience health care over here and housing over there and opportunity somewhere else. They experience it all as one life. And when all of the systems don't work together, families are left to navigate the barriers they did not create and should not have to overcome alone. That is why health equity, health equity, health equity, health justice, health equity is bigger than healthcare alone. It is connected to where people live. It's connected to where we learn, where we move, how we move throughout our communities, and whether opportunity is within reach. When we see those connections clearly, we start to understand that no single issue can be solved in isolation. What gives me hope is that this room represents the leadership our region needs. Not because we all think alike, we all don't have the same opinions, but because we're willing to learn together, to challenge one another, and to stay in relationship. Last week, my boss, Milton Little, reminded regional leaders that lasting change does not happen because one organization has the perfect program. It happens when people align their efforts, stay at the table, and hold ourselves accountable for outcomes that matter. I think the same is true here. So I hope that we leave with more than a deeper understanding of the problem. I hope we leave with a stronger commitment to one another and to the future we are building together. One way we can do that is to commit to invert the burden in our own organizations, health systems, and neighborhoods. Where can we work on making systems and processes center people and families better? I heard just a couple of minutes ago that we can increase philanthropic investment in health equity. Hello, United Way. We can expand Medicaid. We can expand MARTA in public health, MARTA in public transportation. We can more deeply embed community health opportunities, specifically mental and behavioral health opportunities in community. We can find our place in the work and work together. Because years from now, success will not be measured by what was said at this breakfast. It will be measured by whether more people in Greater Atlanta can live healthier lives, experience greater opportunity, and tell a different story because you and I, because we chose to act together. Thank you.
Thank you so much, Malika. And just want to say one more thank you to all who jumped in with both feet today. So many just rock stars and heroes for me and mentors, and Reverend Eric, Dr. Akintobi, LaShawn, Victoria, Odetta, Dr. Ahan, and so many more. So thank you, and thank you so much for our RG team that just does this. We're just a few people making it all happen. Thank you, thank you, thank you. And we just appreciate all of our partners that have come to have tables today as well. So please check in with them and take some time to connect before you go, right? Again, this is part of what we see in terms of systems change is what we call civic muscle, right? This is civic muscle in this room. How do we have more of that happening? How do we flex those muscles and make more connections and drive more partnerships and more policy change? A couple of quick announcements.